Hello. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for this CMEO snack. It's entitled Adopting a Tailored Approach to Managing Unmet Needs in Osteoarthritis. This talk is supported by an educational grant from Pfizer. My name is Jason Wilcox. I'm an orthopedic surgeon in Seattle, Washington. I specialize predominantly in sports medicine and a little bit of trauma. As you would expect, given my field, I see quite a bit of osteoarthritis on a regular basis. We have two learning objectives today. The first is to integrate pain management tools for individual pain and function, assessment, goal setting, and monitoring. The second is to evaluate emerging treatments to address unmet needs of current osteoarthritis therapies. So the first thing is, what is osteoarthritis? Now, in the past, it was often considered a misnomer and thought to be unrelated to inflammation, which is what itis often suggests. It was thought that biomechanics and joint loading, trauma, other factors would cause damage to the articular surface of the joint, resulting in cartilage damage, wear, inflammation, etc. Essentially, it was just thought to be wear and tear. Over time, the result of more systemic and local inflammatory changes and even metabolic factors are thought to involve the disease process a little more. Additional factors such as obesity, metabolic syndrome, and even atherosclerosis could potentially play a role. When we think about risk factors that lead to osteoarthritis, you can think of them in terms of local factors as well as systemic factors, and then factors that can be modified and those can not be modified. Some of the things we think about are muscle strength and physical activity, essentially a use it or lose it type scenario. We know that most joints do better when they're moved, when the muscles that support and move the joint are in good shape. The patient tends to report better outcomes, better function. And again, whether that can be a chicken or the egg effect is a little bit difficult to ascertain, but we do know the more function they attain around that joint, the better they are. Occupation can be a risk. Certainly a desk job versus a more labor-intensive job can lead to a higher risk of osteoarthritis. Joint injury, either through occupation or sport or any other function, can lead to osteoarthritis, as well as joint alignment, which you'll see in both columns, as joint alignment can be both modifiable and non-modifiable, depending on whether it was a genetic predisposition or childhood development, or even as osteoarthritis progresses, alignment of the joint can change. More systemic factors that could be modifiable are diet. We certainly know that diet can lead to obesity and other disorders. And there's also a predisposition to obesity in certain families, and as such, that can be a factor in osteoarthritis. Non-modifiable risk factors, of course, being age. The only alternative to aging is much worse than aging itself, so we can't do anything about that. Gender, we know males are more likely to get osteoarthritis early, but as time goes on, women are more affected. Genetics can play a role, as there's certainly hereditary forms of osteoarthritis that seem to affect families more than others. Ethnicity, we know, not only can change whether you get osteoarthritis, but certain populations are more prone to osteoarthritis in certain joints than others. And as above, joint alignment, certain non-modifiables, like those of us who are born with bowed legs. I have genu varum, which is something I've always had and always will, and as such a little bit more at risk than perhaps someone else. Evaluating osteoarthritis in the beginning is often easy. Identifying the location might be one of the easiest ones, as the person's going to come in and typically point to where it hurts. Simple x-ray will often determine whether they have more advanced arthritis or not. Evaluating comorbidities can include looking for other sources of arthritis or even reasons to have arthritis, as well as factors that would preclude you from certain types of treatments or advancing treatment modalities, or even whether they would be a surgical candidate down the road. Assessing signs and symptoms really come down to, again, how do you want to treat this person with pain, function, stiffness? Now, function is probably the one we look at most. Is the disease so bad that we're looking at a scenario where somebody is confined to a wheelchair, or is it the fact that they're frustrated that they have to play doubles tennis instead of single tennis, and that can affect your decision-making tree as far as how to treat this person? Effusion instability and malalignment on an exam are important, as depending again on those factors, we may assume this person is just hurting because of osteoarthritis, but either due to instability such as ligament disruption, that instability may actually be the biggest cause of their pain or even exacerbating arthritis. And so treating instability or malalignment may actually result in relief of their symptoms more so than what it looks like on radiograph alone. The other part is assessing what's around the person, who's there to support them, what their expectations are they sleeping, or even their employment. Does the arthritis affect their ability to work and what type of work they can do, how close they are to retirement, et cetera? All of these go into how you're going to treat this person. I would love to take credit for this. The acronym was given to me of SMART, and that's how we can set realistic goals: specific, measurable, attainable, relevant, and timely. Specific is, what does a patient want to achieve? At the end of the day, oftentimes in medicine, myself included, we can be a little guilty of assigning our own expectations to someone or what we expect. But the simple thing is to ask them, what do you want to be able to do? Or what can you do? What would you like to do that you can't now? And that's an easy thing to both start with, to understand why they're there, as well as what options you have in going forward. Is what you're looking for measurable? On our forms here in clinic, we often ask someone how far they can walk without having to stop secondary to the problem that they're having. Another example would be to ask them, can you walk for 15 minutes 3 times a week, moderate exercise, et cetera. Achievable. Now, are the goals realistic? So here in Seattle, I've had some people who just want to be able to walk to the mailbox, and you think, well, that's fairly realistic. I also have some people who want to be able to climb Mount Rainier, which is just out the window to my left. And that's a mountain where people train to summit Everest, and as such, that may not be a realistic goal, even if your knees and hips are just fine. Me personally, I'd love to play center field for the Yankees. However, due to my declining athletic ability, as well as inability to hit a curveball, I don't think that's a very realistic goal. Now, is it relevant? Now, what is important to the patient? And again, if it's, do you have to walk 15 minutes 3 times a week? Do you want to be able to get to the mailbox? What goals do they actually have, and does it impact their life? And then timely, how long will it take? And how long do they have? Example being somebody close to retirement age, if they have 3 to 5 years left and you're trying to just get them to the end of their career, in which case the stresses on their joints may actually go down enough that they don't need daily, weekly treatment, et cetera. Some of the guidelines for non-surgical management of knee osteoarthritis. On the next slide, a little bit of hip. This is just a general guideline. The authors looked at all available literature and scored it based on strength of evidence, as well as whether they would just make general recommendations based on it. Looking at activity modification, low impact exercise such as Tai Chi, as well as strengthening cardio training, balance training, and just simple land-based exercise. Now, one of the ones that we're most familiar with is Nsaids, either topical or oral. Certainly, if you look at comorbidities, which we discussed earlier, some of these are better options than others. Topical Nsaids are a good option, particularly in people with gastrointestinal disease or those with no comorbidities, as it doesn't have the systemic effects, or at least as much as what you'd see with an oral NSAID. Water exercise tends to be very good when it comes to knee osteoarthritis. Unloading the knee that allows them to walk and or swim seems to be recommended in most groups, again, with the exception of those with cardiovascular disease. Other options, including intra-articular corticosteroid injections or intra-articular hyaluronic acid injections for local control. Again, the effectiveness for all of these are debated as to their efficacy and cost effectiveness, as well as how long they might last. The basic guideline, there's a number of options that are available, each of which have to be tailored depending on the person, how long they'd last, as well as the other systemic effects that they have, which may change which way you would go. Similar guidelines were published by the same authors in the same paper for hip osteoarthritis, most of which are very similar. They often don't recommend Tai Chi or often aquatic exercise in a lot of these patients, as it seems to exacerbate the hip more so than the knee. But again, tailoring this to your patient to see who they are, what they can do, or even what type of swim stroke that they have may play a role. With all this in mind, is something that we see a lot, treating people with activity modification, anti-inflammatories, injections, et cetera. The endpoint for hip and knee osteoarthritis is often knee replacement or hip replacement, respectively. There's a gap between the people who are successfully treated non-operatively with anti-inflammatories, where they're being oral or topical, or people needing a knee or a hip replacement, where people are inadequately treated with the non-operative measures available before they move on to a knee or hip replacement, if they ever do. And as such, this is a target for potential treatment, which is one of the reasons for the talk today. And either person with inadequate pain relief, on anti-inflammatories or the inability to get this joint replacement down the road leaves this open area for potential treatment. And given the success of other treatments for diseases such as rheumatoid arthritis and related disorders, the hope of finding a treatment that may address some of the systemic concerns with osteoarthritis is certainly an area that is currently under investigation. One of these areas is nerve growth factor. It's a neurotrophin involved in pain signaling and nociceptor gene expression. Is thought to contribute to pain hypersensitivity seen during chronic pain and certainly inflammatory episodes involving the knee and the hip. It's been found to be expressed in subchondral bone, which is often the area that we see involved as arthritis becomes more advanced. The thought is that inhibition of nerve growth factor binding to its receptors would block pain-related behaviors, and this has been found in animal models related to osteoarthritis. One of these drugs has been studied is Tenacimad. This particular study is published in JAMA. It's just under 700 patients. The groups were double-blinded and randomized to either receive 2 doses of Tenacimad at equal doses at day 1 and at week 8. The second group to get the 2.5 milligram dose at day 1 and 5 milligrams at week 8, or a placebo. And then primary outcomes were the WOMAC pain score, WOMAC physical function score, as well as the PGA osteoarthritis score. And each of these were found to have significant reductions in pain and increase in function. Treatment response in Tenacimab versus the anti-inflammatory were all shown to have an increase in pain reduction compared to placebo, measured at 30, 50, or 70, or even greater than 90%. The difficulty with the NGF inhibitors, such as Tenacimab, have been found in adverse events. In this particular study, they were found to have a rapid progression of osteoarthritis in a single patient, and there was an increase in joint replacements seen, particularly in the Tenacimab 2.5 milligram and 5 milligram doses compared to placebo. Because of this and other studies, one of which we'll mention in a minute, the risk of rapidly progressive osteoarthritis, the integrated analysis of joint safety was introduced, including with Tenacimab. This was joint safety outcomes were studied by a blind external committee to look for specific factors such as primary osteonecrosis, rapid progressive osteoarthritis, subchondral fractures, as well as pathologic fractures. The results of this group studied 451 patients, 145 of which were adjudicated to have primary outcomes. And as you can see here, the rapidly progressive osteoarthritis occurring 69% and 17%, subchondral fracture and 12%, osteonecrosis and 2%. The proportion of patients found to have these adverse events were higher in Tenacimab treated patients compared to placebo or anti-inflammatories. Another study looking from arthritis and rheumatology was the effect of Fenizumab on osteoarthritis. Each of these groups are also found to have a decrease in the WOMAC pain scores in a dose-dependent fashion. The higher the treatment dose, the bigger the effect on pain. Much as in the study involving Tenacimab, an increase in arthralgia and joint pain, as well as progression of osteoarthritis, was found in this group. As above, the role of NGF inhibitors may be a promising target for research and treatment. There's obviously still questions regarding efficacy and safety. This is an area to probably look for to bridge the gap between osteoarthritis treatment and ventral arthroplasty to fill the unmet needs of treating osteoarthritis. Returning to our earlier slide, SMART goals are not just for patients, but also for us. And what would we like you to take away from this talk be to recognize the complex pathogenesis of osteoarthritis, to be able to set realistic SMART goals with patients and for ourselves to some extent, apply the OARSI guidelines to non-surgical management of osteoarthritis, as well as to evaluate emerging data for unmet needs involving the management of osteoarthritis. Thank you for joining me today for this talk. If you'd like, you can join me for part 2 of this series, where we will discuss best practice strategies for utilizing telehealth in treatment of osteoarthritis. Hope the data I presented gives you something to consider related to the management of patients with osteoarthritis. you can click on the link below and it'll take you to your post-test and evaluation, and you'll be able to print your CME certificate immediately afterwards.